Hello, this is Dr. Morris. I'm doing a lecture on the digestive system or the gastrointestinal system. What I'll be reviewing today is basically the functions of the digestive system, some of the digestive organs, the peritoneal cavity which covers the digestive organs. We'll talk a little bit about the histological organization, then the movement of food through the digestive system, and then some of the endocrine controls of the digestive functions as well. As you know, when we start with the digestive cavity, we start with the oral cavity. This will include the tongue, the salivary glands, and the teeth. Food, when it is swallowed, must enter into the posterior oral pharynx. Then it will pass into the esophagus and then further down into the stomach, then through the distal portion of the stomach, which is referred to as the antrum of the stomach, then through the pyloric sphincter, then into the small intestines, the first portion of the small intestines being referred to as the duodenum, then into the large bowel, then out of the rectal sigmoid colon, through the rectum, through the external environment. First we'll start talking about the oral cavity. We'll go over again a little bit about the esophagus, the histological functions of the esophagus, the histological, makeup of the esophagus, the swallowing mechanism itself, the stomach, the anatomy of the stomach, some regulations in the gastric activity of the stomach, along with digestion and absorption. Absorption actually takes place in the small intestines. And then as we enter into the small intestines, we'll talk a little bit about the histological makeup, some intestinal movement, some of the other organs that are involved in digestion, which include the pancreas, liver, gallbladder, then coordinations between secretions and absorptions. Then as substances move through the large intestines again, we'll talk a little bit about the makeup of the colon, how it anatomically is structured, the histological makeup of the large intestines, and then its role in its function and absorption as well. Now, there are basically two ingredients that are required for catabolic reactions to take place. Oxygen is one of them, and then organic molecules are the other ones. Organic molecules such as carbohydrates, fats, and proteins, which we've talked about in A&P Part 1. Now we'll see how those carbohydrates, fats, and proteins are obtained from our diet and what the role in the digestive system is in obtaining these molecular structures. Working in coordination with the cardiovascular system and the lymphatic system, the GI system provides organic molecules. In effect, the digestive system provides both the fuel that keeps the body cells running and the building blocks needed for cell growth and repair. Now basically when we talk about the digestive system, we're talking about a muscular tube, a closed system. The digestive system, or the digestive tract, also called the gastrointestinal tract or the alimentary tract, has various accessory organs which aids in this functioning of breaking down food products into molecular structures which we can use as an energy source. This starts with the oral cavity, and the oral cavity, the mouth, the pharynx, then leads into the esophagus, stomach, small intestines, large intestines make up the digestive tract. The digestive organs are covered by a tissue layer referred to as the peritoneum and a cavity referred to as the peritoneal cavity. When we talk about the abdominal peritoneal or the abdominal pelvic cavity, this contains the peritoneal cavity. The cavity is basically lined with a serous membrane that consists of superficial mesothelial coverings, a layer of areolar tissue. Serosa or visceral peritoneum covers the organs within the peritoneal cavity. The parietal peritoneum lies on the inner surface of the body wall. The thin layer of peritoneal fluid actually separates the parietal and the visceral surfaces relative to movement, and this means that movement can occur without friction. This will eliminate irritation that can occur in these surfaces if the fluid medium was not present. There's approximately 7 liters of fluid secreted and reabsorbed each day. Although the volume is within the peritoneal cavity, all of that volume is not there at any one time. There's a dynamic process between secretion and absorption in this system. Now, when an individual starts to accumulate fluid in this peritoneal cavity, this accumulation of fluid is referred to as ascites. Patients who suffer from liver disease, kidney disease, and or heart failure can cause an increase in the rate of fluid that moves into the peritoneal cavity. When the accumulation of the fluid creates a characteristic abdominal swelling, it's referred to as ascites. The distortion of the internal organs by the fluid can result in symptoms of heartburn, indigestion, and or even lower back pain. In some severe cases of abdominal ascites, the weight of the fluid actually pushes up against the diaphragm, and the patient also may suffer from respiratory problems or difficulty breathing associated with the large amount of fluid in the peritoneal cavity. Another portion of the cavity that we should discuss are called the mesenteries. This is a portion of the digestive tract, or I should say portions of the digestive tract are suspended within the peritoneal cavity by sheets of serous membrane and connected to the peritoneal peritoneum with visceral peritoneum. Mesenteries also stabilize the position of attached organs and prevent intestines from becoming entangled during digestion or movement or sudden changes in body position. These structures, this tissue structure, helps to keep the colon and the bowel in position. During embryonic development, it's important to recognize what occurs in the digestive tract. The digestive tube is initially suspended by dorsal and ventral mesenteries. In adults, the ventral mesentery is lost except for where it connects to the stomach and the liver. This is at the point of the lesser omentum, and please look in your text and follow this in the illustration, and the liver to the anterior body wall and the diaphragm. This is referred to as the falciform ligament. Your book has an illustration which demonstrates that. Embryonic development of the digestive tract and accessory organs is suspended within the peritoneal cavity by dorsal and ventral mesenteries. A diagrammatic view organization of the adult mesentery demonstrates as the digestive tract enlarges, mesenteries associated with the proximal portion of the small intestines and the pancreas and the ascending and descending portions of the colon fuse to the body wall. This is an illustration taken out of your textbook which demonstrates some of the mesentery to which we refer. Here is the lesser omentum. This is a cut edge of the greater omentum. And again, these are other layers, again, mesocolon of the ascending and descending colon, which fuse to form the dorsal peritoneum. As you can see, these tissue structures would actually attach to portions of the peritoneal wall and hold these organ structures in place. The anterior view of an empty peritoneal cavity shows the attachment sites or fusion shown, as this was demonstrated in the previous slide and in this illustration, which again is taken from your textbook. Other sections, sagittal sections specifically of the mesentery, you can see where the pancreas and the duodenum and the rectoperitoneal are located. Now, the role of the lesser omentum. It stabilizes the position of the stomach. It provides an access route for blood vessels and other structures entering and leaving the liver. The falciform ligament helps stabilize the position of the liver relative to the diaphragm and the abdominal wall. The greater omentum, or the dorsal mesentery of the stomach, becomes greatly enlarged and forms an enormous pouch that extends inferiorly between the body wall and the anterior surface of the small intestines. The function of the greater omentum: it hangs like an apron from the lateral and inferior border of the stomach. Adipose tissue provides padding and protection across the anterior and lateral surface of the abdomen. It provides lipids in the adipose tissue and are important as an energy reserve. It provides insulation and reduces heat loss across the anterior abdominal wall. Now, inflammation can occur in the peritoneal lining, and this is referred to as peritonitis. It's a very painful condition. It interferes with normal functioning of affected organs, can cause significant problems with digestion. In the case of peritonitis, most instances cause from an infectious organism such as a bacterial infection. Physical damage, chemical irritation, bacterial invasion of the peritoneum can lead to severe and even fatal cases of peritonitis. If untreated, such as in appendicitis, peritonitis may be caused by the rupturing of the appendix and the subsequent release of bacteria into the peritoneal cavity. Peritonitis is a potential complication of any surgery in which the peritoneal cavity is open and/or any disease that perforates the wall of the stomach or the intestines. Remember, the intestinal tract is a closed system. The substances that are inside the digestive tract, such as the foods we eat, the foods that pass through the esophagus, the stomach, through the small bowel and the large bowel, are not sterile.
Even though the digestive enzymes inside the stomach have a significant effect on bacteria, and it significantly kills the organisms that we ingest in our foods, it is still not a sterile surface. It's a closed, unsterile system that is basically inside our body, and our body being a sterile system. So if the peritoneal cavity are the linings of the organ systems that are in the GI tract are ruptured or punctured, and these substances leak into the peritoneal cavity, they will cause significant infection. Now, let's change subjects. Let's talk about the movement or the coordinated movement of the muscular tissue in the digestive tract. Now remember, it is smooth muscle that we're talking about in the digestive tract, which differs from skeletal muscle. The smooth muscle in the digestive tract moves by coordinated contractions of the muscularis externa and play a vital role in the movement of material along the digestive tract through a process referred to as peristalsis, and in mechanical processing and through segmentation. The muscularis externa propels material from one portion of the digestive tract to another by contractions. This is known as peristalsis. Peristalsis consists of waves of muscular contraction that move a bolus or a small oval mass of the digestive contents along the length of the digestive tract. The muscularis externa propels materials from one portion of the digestive tract to another by contractions known as peristalsis. Peristalsis consists of waves of muscular contraction that move the bolus or a small oval mass through digestive contents along the length of the digestive tract. Again, an illustration from your textbook demonstrating how muscle contractions will take place. Again, as the fluid bolus is passed through the esophagus, if this is the esophagus, or the lumen of a colon, you can see the muscular contractions will follow the food bolus. Food bolus will continue to pass through the colon. In this case, again, as I see, the anus is located here, so this must be in the large bowel. We can see the smooth muscle contractions which take place before the bolus, and will actually pass the bolus distally through the GI tract. Regulations of digestive activity, we see three mechanisms: a neural mechanism, a hormonal mechanism, and a local mechanism. Each of these factors play a significant role, whether hormonal, neural, or endocrine type factors will play significant roles in the processing of food, both in mechanical stimulation of the muscle layers of the gastrointestinal tract, also in the digestive processes of the gastrointestinal tract. When we look at the neural mechanisms, movement of material along the digestive tract as well as many secretory functions is controlled primarily by neural mechanisms. Neurons are usually considered to be parasympathetic because some of them are innervated by parasympathetic preganglionic fibers. Now, I know we haven't discussed the nervous system in detail yet, and we'll do so toward the end of this semester. But there are two autonomic nervous systems. One, the sympathetic nervous system, which I have referred to previously as the fight or flight system. And then there is the parasympathetic nervous system, which now you can see is primarily involved in the role of digestion. The enteric nervous system is often used to refer to the neural network that coordinates the myenteric reflexes along the digestive tract. There are hormonal mechanisms. The sensitivity of smooth muscle cells under neural command can be enhanced or inhibited by digestive hormones. Digestive tract produces at least 18 hormones that affect every aspect of digestive function. Hormones such as gastrin, secretin, and others are used, which are peptide produced by the enteroendocrine cells in the digestive tract. There are local mechanisms such as prostaglandins, histamines, and other chemicals released into the interstitial fluid that may affect adjacent cells within a small segment of the digestive tract. These local messengers are important in coordinating the response and the conditions such as changes in local pH or certain chemical or physical stimuli that affect only a portion of the tract. Now, let's talk a little bit about the oral cavity, since now we have a general overview of the digestive system. This is an illustration from your book demonstrating the oral cavity. Some of the functions of the oral cavity analysis of material before swallowing. When we take food into our mouth, an analysis, whether we're conscious of that analysis or not, takes place by the mouth. Helps us to quickly determine whether a food is sweet, whether it's sour, whether it's bitter, whether it's spoiled. This analysis takes place immediately upon substances entering the oral cavity. There's mechanical processing by the teeth, the tongue, and the palatal surfaces. There's lubrication by mixing with mucus and salivary gland secretions. There's limited digestion of carbohydrates and lipids as well. Absorption of lipid-soluble drugs also can take place in the mouth as well. Although nutrients are not absorbed in the oral cavity, and I emphasize that fact that nutrients are not absorbed in the oral cavity, the mucosa inferior to the tongue is thin enough and has a significant amount of vascular presence to permit the rapid absorption of lipid-soluble drugs. An example of that is nitroglycerin, which may be administered via an oral route, or I more specifically should say it's administered by a sublingual route. Now remember, when I make the statement lipid-soluble drugs, think about the cell membrane. The cell membrane is a phospholipid bilayer, and so water-soluble substances could not pass through that lipid bilayer. However, a lipid-soluble substance can easily pass through that bilipid membrane, and thus a lipid-soluble drug such as nitroglycerin can be administered through this route. Nitroglycerin, as many of you may be aware of, is utilized to treat an acute angina attack. Angina refers to a person who has coronary artery disease or an occlusion in the circulation to the heart. The gingiva, another portion of the oral cavity, also known as the gums, ridges of the oral mucosa that surrounds the base of each of the teeth, are the alveolar processes in the maxillary bone and the mandible. The roof or floor of the oral cavity. The roof of the oral cavity is formed by the hard and soft palate. The tongue dominates the floor. The floor of the mouth, inferior to the tongue, receives extra support from the gingiohyoid and the mylohyoid muscles. The hard and soft palate. The hard palate is formed by the palatine processes of the maxillary bone and the horizontal plates of the palatine bones. The soft palate lies posterior to the hard palate. A thinner, more delicate mucosa covers the posterior margin of the hard palate and extends onto the soft palate. The primary functions of the tongue. 1. Mechanical processing by compression, abrasion, and distortion. Number 2. Manipulation to assist in chewing and to prepare material for swallowing. Number 3, sensory analysis by touch, temperature, and taste receptors, and for secretion of mucin, an enzyme of lingual lipase. Lingual lipase is involved in the breakdown of lipids or fats early on in the mouth. Some divisions of the tongue: the anterior body of the tongue, also known as the oral portion, and the posterior roof or the pharyngeal portion. Now, the frenulum. The frenulum is the anatomical structure inside the mouth that you should be familiar with. The inferior midline of the lingual frenulum is a thin fold of mucous membrane that connects the body of the tongue to the mucosa covering the floor of the oral cavity. Ducts on 2 pairs of salivary glands open on either side of the lingual frenulum, which serves to prevent extreme movement of the tongue. However, if your lingual frenulum is too restrictive, it can make you talk or speak abnormally. Enzymes are also present in the oral cavity. The first of which we'll talk about is lingual lipase. Enzyme secretion, which contains water and mucin, works over a broad range of pH, a value between 3 and 6, which, as you remember, is a little acidic. Starts lipid digestion almost immediately because lingual lipase tolerates an acid environment. It continues to break down lipids, specifically triglycerides, from considerable time after the food reaches the stomach. The tongue contains 2 groups of skeletal muscles: intrinsic tongue muscles, extrinsic tongue muscles, and both intrinsic and extrinsic tongue muscles are under the control of the hypoglossal nerve, which is cranial nerve number 12, which we'll study more in detail when we do the nervous system. Salivary glands, from the illustration, as you can see, are located again on both sides of the frenulum, frenulum being the tissue that holds the tongue to the floor of the mouth. And then there's also a parotid gland that has a secretory duct, referred to as the parotid duct, that will actually allow secretions to enter into the oral cavity as well. You can see the submandibular salivary glands and the sublingual salivary glands on this illustration. The parotid salivary glands, or large parotid glands of salivary glands, lie inferior to the zygomatic arch and deep to the skin and covers the lateral and posterior surface of the mandible. The parotid salivary glands produce a thick, serous secretion containing a large amount of saliva and an enzyme that breaks down starches, which is the second enzyme that we'll now talk about that's produced in the oral cavity, referred to as amylase. Amylase specifically breaks down starches, complex carbohydrates. The secretion of each parotid gland is drained by a parotid duct, also referred to as the Stenson duct, which empties into the vestibule at the level of the second upper molar. The sublingual salivary glands are covered by a mucous membrane on the floor of the mouth. These glands produce a watery mucus secretion that acts as a buffer and a lubricant. Sublingual ducts, or the ravenous ducts, open along either side of the lingual frenulum. The submandibular glands are situated in the floor of the mouth along the inner surfaces of the mandible within the depression called the mandibular groove. The submandibular glands secrete a mixture of buffers, glycoproteins called mucin, the salivary amylase. The submandibular ducts, or the Wharton ducts, open into the mouth on either side of the lingual frenulum, immediately posterior to the teeth. Saliva are produced by these glands. Approximately 1 to 1.5 liters of saliva are produced each day. 99.4% of this is water. The remaining 0.6% includes an assortment of electrolytes, principally buffers, glycoproteins, antibodies, enzymes, and waste products. Glycoproteins, called mucins, are primarily responsible for the lubricating action of saliva. Buffers in saliva keep the pH in our mouth about 7 and also prevent the buildup of acids produced by bacterial action. In addition, saliva contains antibodies, IgA, and lysosomes that help control the population of oral bacteria. Lubricating the mouth is also another function of saliva, along with moisturizing, lubricating materials in the mouth, dissolving chemicals that can stimulate taste buds and provide sensory information about the material. Now, the digestion of carbohydrates by amylase and the digestion of lipids in that regard by lipase occur in the mouth, or at least begin in the mouth, initiating the digestion of complex carbohydrates before these materials are actually even swallowed. The same is in effect for certain types of lipids. The enzyme involved for carbohydrates is the salivary amylase, which is also known as ptyalin or alpha amylase. Digestive processes begin in the oral cavity. It is not completed there, however, and no absorption of nutrients occurs across the lining of the oral cavity. Saliva also contains a small amount of lingual lipase that is secreted by the gland and the tongue. A disease condition that can affect at least one of the secretory glands is referred to as mumps. Most often targets the salivary glands, especially the parotid gland or the parotid salivary gland. It can also affect the other glands as well. Infections typically occur at the age of 5 to 9 years of age. The first exposure stimulates the production of antibodies and in most cases confers permanent immunity. Active immunity can be conferred by the utilization of immunizations, commonly referred to as MMR, which stands for measles, mumps, and rubella. Mumps in adults are a more serious problem. In post-adolescent males, the mumps virus can infect the testicles and can cause sterility. Infections in the pancreas by mumps or by the mumps virus can produce temporary or permanent diabetes as well. As you may recall from our discussion in the endocrine system, the beta cells, the Isles of Langerhans in the pancreas, produce insulin. A mumps infection in these cells can certainly destroy the cells either temporarily or on a permanent basis. Other organ systems include the central nervous system, can be affected by severe cases. An effective mumps vaccine is also available. Now, we'll talk a little bit now about the salivary reflex. Again, parasympathetic nervous system is the autonomic system that predominates in the digestive system. Parasympathetic outflow originates in the salivatory nuclei of the medulla oblongata and the synapse in the submandibular and otic ganglion. Again, these are aspects of the nervous system which we'll go into more detail about when we talk about the nervous system. Any object in the mouth can trigger a salivary reflex by stimulating receptors monitored by the trigeminal nerve, or cranial nerve number 5, or by stimulating the taste buds innervated by cranial nerves number 7, 9, and 10. Parasympathetic stimulation accelerates secretion by all of the salivary glands, resulting in the production of large amounts of saliva. Another structure in the oral cavity are the teeth. And I will just briefly go over the teeth, just basic structures of the teeth. It's not my intention to make any of you dentists, but you should have just a general appreciation for the type of teeth that are located in the mouth. There are upper teeth, teeth of the upper jaw, and then teeth of the lower jaw, which are divided in divisions of incisors, canines, and then molars. Again, the overall structure of the tooth, there is an enamel covering, referred to commonly as the crown. Then there is the more deeper lying structure, such as the dentine, which lies just under the enamel, and then the pulp. As you can see in the pulp, not only are the nerves and the blood vessels located here, but there is generally a soft tissue matrix that's located in this area as well. Also, as you can see, the nerves and the blood vessels extend deep through the teeth, also known as the root canal, which is located in the portion of the tooth referred to as the root. The occlusion of opposing surfaces of the teeth perform the chewing and or mastication of food. Mastication breaks down tough connective tissue of meat, plant fibers, vegetable matter, and also helps saturate material with the saliva, which is secreted, and other digestive enzymes in the mouth. Again, 4 types of teeth: incisors, cuspids or canines, bicuspids or premolars, and molars. Functions of teeth overall: incisors are the blade-shaped teeth located in the front of the mouth, useful in clipping and cutting, such as you nip off the tip of a carrot. The cuspids are the canine, or the conical teeth, shaped along the ridge line with pointed tips. They are used for tearing and slashing. Bicuspids or premolars have flattened crowns and prominent ridges, and then the molars are very large. Flattened crowns, prominent ridges, they are excellent at crushing and grinding food matter that is brought into the mouth. This is another illustration taken from your book, and actually gives the time of the maturation of the teeth inside the mouth. We have primary dentition, which consists of 2 incisors, 1 cuspid, a pair of deciduous molars. These teeth will later be replaced by adult or secondary dentitia, or permanent dentitia. The adult jaw are larger and can accommodate more than 20 permanent teeth. 3 additional molars appear on each side, the upper jaw and lower jaw, as the individual ages, extending the length of the rows of teeth posteriorly, which brings permanent teeth to a count of 32. Now, in some individuals, as those later molars come in, sometimes it displaces the arrangement of teeth, and these teeth at times may need to be removed to allow for correct positioning of the teeth. Now, bacteria exist in the mouth. Bacteria that leads to pathology, such as an inflammation of the gingiva, also called gingivitis, can occur. When you brush or massage your gums, you stimulate the epithelial cells and strengthen the attachment. A condition referred to as gingivitis is a bacterial infection in the gingiva that can occur when the attachment breaks down. Adequate amounts of calcium, phosphate, and vitamin D during childhood development is essential for the enamel coating, and it has to be completed, and it must be complete to provide resistance to decay. Tooth decay generally results from the action of bacteria that inhabits the mouth. Bacteria adhering to the surfaces of the teeth produce a sticky matrix that actually traps food particles and creates deposits known as dental plaque. Over time, this organic material can become calcified, forming a hard layer of tartar. There are organisms that specifically attack these sites. Streptococcus mutans is the most abundant bacteria at these sites. There is a vaccine that's now being developed to promote resistance to it, and thereby will prevent dental caries. Streptococcus mutans, or another bacterium, reaches the pulp and infects it. Pulpitis will result. Treatment generally involves the complete removal of the pulp of the tissue, usually the sensory innervation and all areas of decay. The pulp cavity is then packed with the appropriate material this procedure, typically referred to as a root canal. In periodontal disease, bacteria and plaque remain with the gingival sulcus in extended periods of time. Acids generated will then erode the connections between the neck and the tooth and the gingiva. The gums appear to recede from the teeth, and the periodontal disease develops. As this disease progresses, bacteria attacks the cementum, eventually destroying the periodontal ligament and eroding the bone at the alveolus. The deterioration loosens the tooth, and it falls out, or it must be pulled out. Periodontal disease is the most common cause of loss of teeth. Now, as we move further through the digestive tract, we then enter into the pharynx. Now, remember, the pharynx is a common passageway. We've talked about this area before when we talked about the respiratory system, but it's a common passageway through which solid foods and liquids will pass, and also the inhaled air. The pharynx involves an epithelial lining, and divisions of the pharynx include the nasopharynx, the oropharynx, and the laryngopharynx. Pharyngeal muscles in swallowing are significantly involved in the swallowing mechanism. The pharyngeal constrictor muscles push the bolus of food toward the esophagus. The palatopharyngeus and the stylopharyngeus, these muscles will elevate the larynx. The palatal muscles elevate the soft palate and adjacent portions of the pharyngeal wall. These muscles cooperate with muscles of the oral cavity and the esophagus to initiate swallowing, which pushes the bolus along the esophagus and into the stomach. Now, this is an illustration of the esophagus, and you will have some laboratory questions based upon this photograph. Primarily, I would like you to appreciate the epithelial lining of the esophagus. If you remember from A&P Part 1, when we talked about the esophagus, or we talked about tissue areas that were exposed to the external environment, we described squamous epithelial tissue, or specifically stratified squamous epithelial, as tissue which lines these portions of the body that have exposure to the external environment. The esophagus has exposure to the external environment because the foods that we eat are brought in and initially make contact with the esophagus. Because of repetitive and the abrasiveness of the food, it can cause a degree of trauma and or tearing to the surface cells of stratified squamous epithelial, so they constantly have to be able to be resupplied with new cells through a process of mitosis, which we've talked about during A&P Part 1. But the initial epithelial lining that we see in the esophagus is referred to as the stratified squamous epithelial tissue. Some of the functions of the esophagus: it's a hollow muscular tube with a length of approximately 25 centimeters and a diameter of about 2 centimeters at its widest point. It enters into the abdominal pelvic cavity through the esophageal hiatus, which is an opening through the diaphragm. Remember, the diaphragm is a large flat muscle that sits at the base of the lung, but it separates the thoracic cavity from the abdominal cavity. The esophagus actually passes through this muscular structure through what's referred to as the esophageal hiatus. Now, keep in mind the name esophageal hiatus. You may have heard the term previously, hiatal hernia, which is derived from this name. A hiatal hernia is a pushing or a bulging of the abdominal contents through this opening, through this esophageal hiatus. That's referred to as a hiatal hernia, and I'll discuss that a little bit later on in the lecture. Neural innervation of the esophagus: again, the parasympathetic nervous system predominates. There are also some fibers of the sympathetic nervous system. This forms the esophageal plexus. The upper and lower esophageal sphincters play an important role. Sphincters are muscles that will close the opening of the esophagus to the stomach. There is an upper esophageal sphincter as well that is not so clearly defined. Resting muscle tone in the circular muscular layer of in the superior 3 centimeters of the esophagus normally prevents air from entering the esophagus. A comparable zone at the inferior end of the esophagus normally remains in a state of active contraction. This condition prevents the backflow of material from the stomach into the esophagus. The phases of swallowing. There are 3 phases of swallowing: a buccal phase, a pharyngeal phase, and esophageal phase. Excuse me. Phases of swallowing are illustrated in your textbook, which delineate the positioning of the food bolus in the buccal phase, the pharyngeal phase, and then the esophageal phase. The buccal phase is strictly voluntary. Once the bolus enters the oropharynx, reflex responses are initiated and the bolus is moved toward the stomach. The pharyngeal phase begins as the bolus comes into contact with the palatoglossal and the palatopharyngeal arches in the posterior pharyngeal wall. The swallowing reflex begins when tactile receptors on the palatal arches and the uvula are stimulated by the passage of the food bolus. The information is relayed to the swallowing center of the medulla oblongata over the trigeminal and glossopharyngeal nerves. Motor commands originating at this center then target the pharyngeal musculature, producing a coordinated and stereotyped pattern of muscle contraction. The esophageal phase of the swallowing begins as the contraction of the pharyngeal muscles forces the bolus through the entrance of the esophagus. Once in the esophagus, the bolus is then pushed toward the stomach at a peristaltic wave. The approach of the bolus triggers the opening of the lower esophageal sphincter, and the bolus then continues into the stomach. Now, there are conditions that can affect swallowing, and they have specific names. You should be familiar with the term achalasia. Achalasia is a constriction in the lower esophageal sphincter. Esophagitis is an inflammation in the esophagus. The next organ in the digestive system is the stomach. This illustration demonstrates to you the cardinal parts of the stomach. You should be familiar with the esophagus. The fundus of the stomach, as you can see, sits somewhat superior to the portion of the esophageal sphincter. The lesser curvature of the stomach, the greater curvature of the stomach, and then the other parts of the stomach include the pyloric antrum, the pyloric channel, and then the pyloric sphincter, again another muscle that will close off openings, closing off the opening from the stomach to the duodenum. Also, you should be familiar with some of the structural features of the stomach, including the rugae of the stomach, the cardia and the muscle layers, longitudinal muscle layers of the stomach, and then circular muscle layers of the stomach as well. As you can see, there is a brisk blood supply to the stomach as well, provided by organs of the left gastroepiploic vessels. The lesser and greater curvature of the stomach. A lesser curvature of the stomach forms the medial surface of the organ, and then along greater curvature forms the lateral surface of the stomach. Again, lesser curvature and greater curvature of the stomach. Four major functions of the stomach, which you should be familiar. The bulk of storage of ingested food, mechanically broken down and ingested food, the disruption of chemical bonds in food material through the action of the acid of the enzymes, the production of intrinsic factor, which is a glycoprotein whose presence in the digestive tract is required for the absorption of vitamins in the small intestine. Should be familiar with the term chyme. This is ingested substance combined with secretions of glands of the stomach, produces a viscous, highly acidic, soupy mixture of partially digested food. Again, this is referred to as chyme. This is a gross anatomical picture of the stomach. Again, the same landmarks that I pointed to you in the illustrations are pertinent on this picture. Please note the fundus of the stomach. Please note the lesser curvature of the stomach. The greater curvature of the stomach, which is somewhat lost in the omentum, or the greater omentum of the stomach. The gastroepiploic vessels, which provide blood supply. The pylorus and the pyloric antrum of the stomach. The sphincter, and then the first portion of the small intestine is referred to as the duodenum, located there. Four regions of the stomach you should be familiar: the cardia, the fundus, the body, and the pylorix. The cardia of the stomach is the smallest part of the stomach and consists of the superior medial portion of the stomach within 3 centimeters of the junction between the stomach and the esophagus. The fundus is the portion of the stomach that is superior to the junction between the stomach and the esophagus. The fundus contracts the inferior, or contacts the inferior posterior surface of the diaphragm. The body of the stomach between the fundus and the curve of the J is the body of the stomach. The body is the largest region of the stomach, and its function as mixing tank or a mixing tank for the ingested food. It also provides secretions that are produced in the stomach. The gastric gland and the fundus in the body secrete most of the acids and the enzymes involved in gastric digestion. The pylorus is the curve of the J. The pylorus is divided into the pyloric antrum, which is connected to the body, the pyloric channel, which empties into the duodenum, the proximal segment of the small intestine. As mixing movement occurs during digestion, the pylorus frequently changes shapes. A muscular pyloric sphincter regulates the release of chyme into the duodenum. Glands in the pylorus secrete mucus. It's important in digestive hormones such as gastrin, or hormone that stimulates the activity of the gastric cells. The stomach receives blood from the left gastric artery, the splenic artery, which supplies the left gastroepiploic artery, which I demonstrated to you in the illustrations, and then the common hepatic artery, which supplies the right gastric, gastroduodenal, and the right gastroepiploic arteries. The stomach is drained by both the gastric and gastroepiploic veins. Now, the gastric epithelium is a secretory sheet which produces a carpet of mucus that covers the inferior surface of the stomach. The alkaline mucus layer protects the epithelial cells against the acid and enzymes of the gastric lumen. This is an illustration again from your textbook demonstrating to you the cross-sectional view and histological view of the stomach. There are gastric glands in the stomach as well. The fundus and the body of the stomach each have gastric pits which communicate with several gastric glands which extend deep into the underlying lamina propria. Gastric glands are dominated by two types, parietal cells and chief cells, both of which you should become familiar with. Together they secrete about 1,500 cc's or 1,500 milliliters of gastric juice each day. Parietal cells are especially common along the proximal portion of each gastric gland. The parietal cells secrete hydrochloric acid. These cells also secrete intrinsic factor, a glycoprotein that precipitates or that facilitates the absorption across the intestinal lining. The vitamin is essential for normal erythropoiesis, or the manufacturing of red blood cells. Now, the secretion of hydrochloric acid. An active parietal cell generates by dissociation of carbonic acid within the cell. Bicarbonate is exchanged in the interstitial fluid. The chloride ions diffuse into the lumen of the gastric gland as hydrogen ions are transported out of the cell, which is what the illustration here from your textbook will show. 4 important functions of acidity. Acidity of gastric juices kills most of the microorganisms that are ingested in food. I alluded to this earlier. Acidity denatures proteins and activates most of the enzymes in foods. Acidity helps break down plant cell walls and connective tissue in meat. An acidic environment is essential for the activation and function of pepsin, a protein digestive enzyme secreted by chief cells. Gastrin is produced by G cells, which are most abundant in the gastric pits of the pyloric antrum. Gastrin stimulates secretion by both parietal and chief cells, as well as contraction of gastric wall that mix and stir gastric contents. Substance called somatostatin. The pyloric gland also contains D cells, which releases somatostatin. This is a hormone that inhibits the release of gastrin. D cells continuously release their secretions into interstitial fluids adjacent to G cells. Inhibition of gastrin production may be overpowered by neural and hormonal stimuli in the stomach in preparing for digestion or is already engaged in digestion. Now, a condition, an abnormal condition referred to as gastritis, is a superficial inflammation of the gastric mucosa, also referred to as gastritis. The condition can develop after a person has swallowed drugs, including alcohol, aspirin. Gastritis can also appear after several emotional and physical stresses, bacterial infections in the gastric wall, or the ingestion of strongly acidic or alkaline chemicals. Ulcers Peptic ulcers develop when digestive acids and enzymes manage to erode their way through the defenses of the stomach lining in the proximal portion of the small intestines. Specific location of an ulcer is indicated by terms of gastric ulcer, stomach, duodenal ulcer, and the duodenum. Peptic ulcers result from an excessive production of acid or inadequate production of alkaline mucus that defends the epithelium against that acid. Digestion and absorption in the stomach. The stomach performs preliminary digestion of proteins by pepsin and variable periods. It permits the digestion of carbohydrates and lipids, and the salivary amylase and lingual lipase are involved in this role. Protein digestion is not completed in the stomach because it is limited by pepsin's attack on specific types of peptide bonds, all of them. Now, recognize one thing that I have not talked about to this point has been the absorption of nutrients. At this point, as we're still in the stomach, we're only talking about the digestion or the breakdown of the food substances into chemical components. No absorption has taken place at this point. Again, we're still in the stomach. The absorption of nutrients doesn't take place in the stomach, and it's an important point to bring out. The epithelial cells are covered by a blanket of alkaline mucus and are not directly exposed to the chyme. Now, the alkaline mucus is important because, remember, hydrochloric acid is produced inside the stomach. Without the alkaline mucus to neutralize the acid, the underlying lining of the stomach would be eroded. The epithelial cells lack specialized transport mechanisms in the cells that line the small intestines. So, the gastric lining is relatively impermeable to water. Digestion has not proceeded to completion by the time the chyme leaves the stomach. At this stage, most carbohydrates, lipids, proteins are only partially broken down. Absorption of drugs in the stomach, such as ethyl alcohol, can diffuse through the mucus barrier and penetrate the lipid membranes of the epithelial cells. Meals containing large amounts of fat will slow the rate of alcohol absorption because alcohol is lipid soluble. Aspirin in the stomach. Aspirin is also a lipid soluble drug, and we talked about lipid solubility when we talked about the oral cavity and the ability of nitroglycerin, which is also a lipid soluble drug, to absorb under the mouth through the mucosal lining and the blood vessels there in the mouth. So, as we see in aspirin, it's another lipid soluble drug that can enter into the bloodstream across the gastric mucosa. It alters the property of the mucus layer and can promote epithelial damage of the stomach acids and enzymes. Prolonged use of aspirins can cause gastric bleeding, so individuals with stomach ulcers usually avoid aspirin. Stomach cancer, another condition that can occur in the gastrointestinal system. Stomach or gastric cancer is one of the most common lethal cancers. It's responsible for approximately 14,000 deaths in the United States each year. There are higher instances in countries such as Japan and Korea, where the typical diet includes large quantities of pickled, fermented, or smoked foods. The diagnosis of stomach cancer generally involves specialized x-rays. Mucosa can be visualized or inspected utilizing a flexible instrument referred to as an endoscope. So endoscopy or a gastroscope or gastroscopy must be performed. Typically, a biopsy is taken through this scope of tissue to give the diagnosis of cancer. Treatment of stomach cancer involves gastrectomy or removal of a portion of the stomach, surgical removal of part of the stomach, again referred to as gastrectomy. Now, the small intestine. The small intestine's most important digestive and absorptive functions occur in the small intestines. Now, this is the first time that we're actually talking about an organ system in the GI tract, less the lipid-soluble drugs, where we're talking about the absorptive function of the gastrointestinal tract. Chemical digestion is completed, and the products of digestion are then absorbed in the small intestines. The mucosa of the small intestines produces only a few enzymes. The pancreas involves the digestive enzymes as well as the buffers that help neutralize the chyme as it leaves out of the stomach. The liver secretes bile, which is solution stored in the gallbladder and subsequent discharged into the small intestine. Bile contains buffers and bile salts, compounds that facilitate digestion and absorption of lipids. Chemical digestion and absorption in the small intestines are as follows. The pancreas provides digestive enzymes as well as buffers that help neutralize chyme. The liver secretes bile, a solution stored in the gallbladder for subsequent discharge into the small intestines. The bile contains buffers and bile salts, compounds that facilitate digestion and absorption of lipids. Plicae, villi, and microvilli. And the small intestine contains roughly 800 plicae. Their presence greatly increases the surface area available for absorption. The mucosa of the small intestine is thrown into a series of finger-like projections referred to as intestinal villi. These structures are covered by simple columnar epithelial cells carpeted with microvilli. And this is an illustration from your textbook demonstrating that anatomy. Again, villi and microvilli we talked about in A&P Part 1 as far as structures that increase the surface area important in absorption. And remember now that we're in the small intestines, and the primary role of the small intestine is the absorption of the nutrients of our system. And so we'll see significant amount of microvilli and villi in this system. Small intestines were a simple tube with just smooth walls. The mucosa contains plicae. Each plicae supports a forest of villi. Each villus is covered by epithelial cells whose exposed surfaces contain microvilli. The arrangement increases the total surface area for absorption by a factor of more than 600 to approximately 2 million. This is a histological view to be able to look at the structures in the small intestines. Again, plicae, and then covered by microvilli and then microvilli. Now, lacteals are also an important part of this absorption factor. Capillary and nerve endings, each villus contains a lymphatic capillary, which is referred to as lacteals. We've already talked about the lymphatic system and its important in transport of materials. We see now that the lacteals transport materials that are unable to enter into blood capillaries. For example, absorbed fatty acids are assembled into protein lipid packages and that are too large to diffuse into the bloodstream, and the lacteals can obtain this absorption or can facilitate this absorption. This is a structure, again, you can see the combination of the vein, the artery, and then the lacteal, which is the lymphatic vessel. Brunner's glands, also called submucosal glands, which produce copious quantities of mucus when the chyme arrives from the stomach. The mucus protects the epithelium from the acidity of the chyme, which contains buffers that also helps elevate the pH of the chyme. Remember, the stomach produces hydrochloric acid, and so when these substances are released into the colon, there's a significant amount of acidity that has to quickly be neutralized because the pH of the small bowel is actually more of an alkaline or basic level. Some regional specializations. The duodenum has a few plicae and their villi are small. The primary function of the duodenum is to receive the chyme from the stomach and to neutralize its acids before they can damage the absorptive surfaces of the small intestines. Over the proximal half of the jejunum, which is this more distal portion of is a little more distal than the duodenum. However, the plicae or villi are very prominent. Now, some individuals may have to go gastric surgery, whether that's due to severe peptic ulcer disease or any other type of abnormality such as gastric cancer. However, most of the nutrient absorption that occurs before the ingestion of material reaches the ileum. One rather drastic surgical method for promoting weight loss, which is another example, is the removal of a significant portion of the jejunum. Typically in this gastric surgery, not only is the distal portion of the stomach removed, but the proximal portion of the small bowel as well. This would include the jejunum. The reduction in the absorptive area causes a marked weight loss, but may not interfere with adequate nutrition. But the side effect can occur where these individuals certainly can have compromises in their nutritional intake. The pancreas, also an organ involved in digestion and absorption. The head of the pancreas lies within the loop that forms the duodenum as it leaves the pylorus. The body of the pancreas extends toward the spleen. The tail is short, blunted, and rounded, and the pancreas is retroperitoneal. Now, when I say that the pancreas is involved in this mechanism of absorption, I mean that the pancreatic enzymes that are released from the pancreas enter into the small bowel at the point of the duodenal papilla. These enzymes are what facilitate the breakdown of certain molecular structures and promotes absorption in the small intestines. The pancreas has both an exocrine and an endocrine function. This is an illustration from your textbook that shows the portions of the pancreas. Now recognize the body of the pancreas and the tail here will lie away from the duodenum. This portion, the head of the pancreas, actually can engulf or enwrap the duodenum as well. And so there are also significant blood vessels and other ducts that pass in the same location. As you can see, the pancreatic duct leads and joins a duct that comes from the liver and the gallbladder, also referred to as the common bowel duct, and jointly they will enter into the duodenum and secrete their digestive juices into the duodenum at the duodenal papilla. The exocrine function of the pancreas, primarily the exocrine organ, produces digestive enzymes and buffers. The exocrine cells include acinar cells and epithelial cells that line the duct system. Together, the acinar cells and the epithelial cells secrete pancreatic juices, an alkaline mixture of digestive enzymes, water, and ions into the small intestine. The large pancreatic duct, or the duct of Wirsong, delivers these secretions to the duodenum. The endocrine cells of the pancreatic islet secrete insulin and glucagon into the bloodstream. Now, here's a look at the biliary system. Biliary system, as we refer to it, commonly involves the gallbladder, which is a reservoir that stores a substance called bile, B-I-L-E, produced in the liver, but stored here in the gallbladder, and direct secretion of bile from the liver itself, which would enter into a common bile duct, which is a joining of or merging of the cystic duct, which comes from the gallbladder, and the hepatic duct, or the common hepatic duct, as it comes from the different lobes of the liver. Now, remember and differentiate. There is the cystic duct, there is the common bile duct. There is the hepatic ducts, a left hepatic duct, a right hepatic duct, a common bile duct, and then this joins the cystic duct to form the common bile duct. As you can see, further travels down the distally, and then it will join again the pancreatic duct here at the duodenal papilla, which then will secrete these substances are then secreted into the duodenum. The pancreatic duct extends within the attached mesentery to each of the duodenum, where it will meet the common bile duct from the liver and the gallbladder. The two ducts then empty into the duodenal ampulla, a chamber located roughly halfway through the length of the duodenum. Pancreas secretes about 1,000 cc's of pancreatic juices. The secretory activities are controlled primarily by hormones from the duodenum. When chyme arrives in the duodenum, secretin is then released. This hormone triggers pancreatic secretions of a watery buffery solution, a pH of about 7.5 to 8.8. Secretions contained bicarbonate, phosphate, buffers will help elevate the pH of the chyme. Cholecystokinin, a different duodenal hormone, and cholecystokinin stimulates the production and secretion of pancreatic enzymes. Pancreatic enzyme secretion also increases under the stimulation of the vagus nerve, which again is primarily a parasympathetic nerve. Pancreatic enzymes such as pancreatic alpha amylase or carbohydrase are enzymes that break down certain starches. Pancreatic alpha amylase is almost identical to salivary amylase. Pancreatic lipase, which breaks down certain complex lipids, releasing products such as fatty acids that can easily be absorbed. Nucleases, which break down nucleic acids. Proteolytic enzymes, which break down certain proteins apart. Now, the pancreas, as we've talked about other organ structures, can also become inflamed. The condition is referred to as pancreatitis. This is an inflammation of the pancreas, a blockage in the excretory ducts, bacterial and or viral infections, ischemia, or drug reactions, especially those involving alcohol, are among the factors that may produce extreme painful condition. These stimuli provoke a crisis which, by injuring exocrine cells, will, or at least a portion, or can at least injure a portion of the organ itself. Lysosomes in the damaged cells then activate the proenzymes and then autolysis begins. And basically, the digestive enzymes of the pancreas itself begin to destroy the pancreas tissue, the pancreatic tissue itself. Proteolytic enzymes digest the surrounding undamaged cells, activating their enzymes, starting an awful chain reaction. Pancreatitis, in most cases, only a portion of the pancreas will be affected, and the condition will subside in a few days. In about 10 to 15% of the individuals who are affected by pancreatitis, the process does not subside, and the enzymes can then ultimately destroy the pancreas. If the islet cells are damaged, or diabetes mellitus may result from these types of conditions. Now, another important organ in the digestive system is the liver. Three general categories of function for the liver: metabolic regulation, hematological regulation, and then bowel production. Now, we're primarily focused on the bowel production, but recognize that the liver has more than 200 functions. You can see its positioning here now in the right upper quadrant of the abdominal wall. Its relationship with the other organ structures is very prominent and very key. You're looking here to establish your location. This is posterior. You can see the vertebral column here. You can see the sternum here, so you see this is an anterior location. So we must be looking from an inferior position, looking superior, as we know that the liver lies on the right side of the body, at the right upper quadrant location. You can see the positioning of the stomach in its relationship here to the liver as well. This is the actual cross-sectional photo of the torso where it has been transected. These are the various lobes of the liver, right and left lobe, and you will see there's also a caudate lobe, which is located in a more medial position of the liver as well. And then there's also a lower quadrate lobe as well. The positioning of the gallbladder, which sits in an inferior position to the liver, the falciform ligament, when we discuss the omentums and other ligamental structures that hold different organs in place, the falciform ligament and the round ligament are remnants from embryonic development. There's also the coronary ligament there as well. You can also see its relationship with the inferior vena cava. Now, for metabolic regulation, we can see the liver is a primary organ involved in regulating the composition of circulating blood. All the blood leaving the absorptive surfaces of the digestive tract enter the hepatic portal system and follows through the liver. The liver cells extract nutrients or toxins absorbed from the blood before it reaches the systemic circulation through the hepatic veins. Excess nutrients are removed and stored, and deficiencies are corrected by mobilizing stored reserves. In carbohydrate metabolism, the liver stabilizes blood glucose levels at about 90 millimeters per deciliter. If blood glucose levels drop, hepatocytes break down glycogen reserves, which are stored in the liver, and release glucose into the bloodstream. They are also synthesized glucose from other carbohydrates or from available amino acids. The synthesis of glucose from other compounds in a process is referred to as gluconeogenesis. In lipid metabolism, the liver regulates circulating levels of triglycerides, fatty acids, and cholesterols, and when those levels decline, the liver breaks down its lipids reserves and releases them into the bloodstream. When the levels are high, the lipids are removed from storage. Now, amino acid metabolism, the liver also removes excess amino acids from the bloodstream. These amino acids can be used to synthesize proteins and can be converted to lipid or glucose for storage. The removal of waste products also is seen as a role of the liver. When converting amino acids to lipids or carbohydrates, or when breaking down amino acids to get energy, the liver strips off amino groups in a process called deamination. Ammonia, which is a toxic waste product, can be formed in this process of deamination. The liver neutralizes ammonia by converting it to urea, which is a fairly harmless compound that's excreted in the kidneys. Other waste products, circulating toxins and drugs, are also removed from the blood for inactivation, storage, and/or secretion. Now, the storage of vitamins and minerals. Fat-soluble vitamins such as A, D, E, and K, and vitamins are absorbed from the blood and stored in the liver. These reserves are called upon when our diet contains inadequate amounts of those vitamins. For mineral stores, the liver converts iron reserves to ferritin and stores protein-iron complexes. For drug inactivation, the liver removes and breaks down circulating drugs, thereby limiting the duration of their effects. Most physicians and/or nurses and/or other healthcare providers must take into account the rate at which the liver removes drugs from the bloodstream. For example, a drug that is absorbed relatively quickly must be administered every few hours to keep plasma concentrations at a therapeutic level. In cases of liver disease, any condition that severely damages the liver can represent a serious threat to life. Remember, the liver carries out about 200 separate functions. The liver has limited ability to regenerate itself after injury, but the liver function will not fully recover unless normal vascular pattern returns. So, in cases of hepatic cirrhosis, where the blood vessels, where the pattern of circulation has been significantly altered, this is characterized by the replacement of lobules with fibrous tissue. Fibrous tissue is scar tissue. Hepatitis, which is an inflammation that can be caused by a viral infection, significantly destroys the tissue of the liver by leading to cirrhosis. Now, the bile is produced in the liver, and some of the functions of bile are important to know. Most dietary lipids are not water soluble. Mechanical processing in the stomach creates large droplets containing a variety of lipids. Bile salts break the droplets apart in a process known as emulsification, which dramatically increases the surface area of the fat, which makes it accessible to enzymatic attack. The next portion of the digestive tract that's important to note is the large bowel. In the histological review, I've already gone over the sections of the bowel that are important for you to know. You're already familiar with the blood supply to the large bowel, mainly provided from the superior mesenteric artery, a branch of the abdominal aorta, and the inferior mesenteric artery, a lower branch or more inferior branch off of the abdominal aorta. You also should note the portions of the bowel: the cecum, which receives material from the small intestines via the ileocecal valve; the ascending colon; the hepatic flexure or the right colic flexure; the transverse colon; and then the left colic flexure or the splenic flexure; then the descending colon; and then the rectosigmoid colon. Functions of the large intestines. The large intestines primarily involved with the reabsorption of water and the compaction of intestinal contents into feces. The absorption is important for vitamins to be liberated by bacterial action, the storage of fecal material prior to defecation. A condition of concern, and you should be familiar with, is colon cancer. Colon cancer is relatively common. Approximately 1,114 cases were diagnosed in the United States each year. Numbers probably a little bit higher than that, because these are 2002 numbers. There are 34,700 cases of rectal cancer. In 2002, it's estimated that 47,900 deaths occurred from colon cancer and another 8,700 deaths from rectal cancers. The mortality rate of these cancers remains high, and the best defense appears to be early detection and prompt treatment. Diagnosis and screening involves a standard screening test, involves checking the feces for blood. It's a simple procedure that can easily be performed on a stool sample as a part of a routine physical exam. For those with increased risk because of either family history, associated diseases, older individuals, a history of smoking, visual inspection of the lumen by a fiber optic instrument referred to as an endoscope, the person undergoes a procedure called a fiber optic colonoscopy, and this is recommended. This is the tissue layers of the large intestines, somewhat different now than what we looked at when we looked at the small intestines. Strikingly is the absence of the villi and microvilli. As you can see, the colon has large intestines has a smooth surface. Still columnar epithelium, but we don't see the surface appendages as we saw in the small intestine. Again, major characteristics of the colon: lax villi, the abundance of goblet cells, the presence of distinctive intestinal glands, the mucosa of the large intestines does not produce enzymes. Any digestion that occurs results in an enzyme introduced in the small intestines from bacterial action. The mucus provides lubrication as fecal material becomes less moist and more compact. Another disease condition that can strike the gastrointestinal tract, this specifically in the large bowel, is called diverticulosis. Pockets of diverticulum, or little pockets, form in the mucosa, generally in the sigmoid colon. The pockets get forced outward, probably by pressure generated during defecation. If they push through weak points in the muscularis externa, the pockets form a semi-isolated chamber and is subject to recurrent infection or inflammation. The infections cause pain, occasionally bleeding, and the condition is known as diverticulitis. Inflammation in other portions of the colon are called colitis. Now, there is bacteria in the colon. Again, remember, the gastrointestinal system is not a sterile system. It's a closed system that's inside our body. Our body is sterile, but this closed system inside of it is not sterile. So bacteria that reside in the colon generate 3 vitamins that supplement our diet. So these bacteria carry out a very important role. Vitamin K, which is a fat-soluble vitamin that the liver needs in order to synthesize 4 clotting factors, which include prothrombin, is very important. Intestinal bacteria produce roughly half of our daily vitamin K requirements. Another vitamin, biotin, which is a water-soluble vitamin, important to various reactions, notably those of glucose metabolism. Pantothenic acid, a water-soluble vitamin required in the manufacturing of steroid hormones, and some